research to reach goals, awareness, assessment, adaptation, acceleration, a guidance document. I would like to briefly review the agenda for this webinar. First, I will explain how to submit a question to our presenters. Then, Rebecca Roper, Director of the Practice Research Network Initiative at the Agency for Healthcare Research and Quality, will introduce today's presenters. Please see the slide being shown for our presenters' disclosures. You may submit a question at any time. To submit a question, type a question under the Questions section on your GoToWebinar control panel and hit Send as shown in the screenshot on this slide. At the end of each section, as time allows, your questions will be read out loud and our presenters will respond. After today's webinar, a copy of the presentation slides will be emailed to participants. The recording of today's webinar will be posted to YouTube in the coming weeks. We will notify today's participants when the video becomes available. If at any point during this webinar you have trouble hearing our presenters, please try hanging up the phone or headset and dialing back into the webinar. I will now turn the presentation over to Ms. Roper.
Thank you, Christina. So good afternoon. Dr. Dave Gustafson and Dr. Kim Johnson are going to lead us through a wonderful interactive presentation of the Using Rapid Cycle Research to Reach Goals, Awareness, Assessment, Adaptation, and Acceleration. With respect to how we're going to be conducting this particular webinar, we're going to have the presenters who are together in Wisconsin give presentations by sections and then offer you the opportunity to type in your written questions. And I will be sharing those orally with our presenters for discussion. Before I introduce our presenters, I want to recognize that last year, in 2014, at the North American Primary Care Research Group, Dr. Gustafson and Dr. Johnson joined Lloyd Provost and Dr. Bernard Uligman, who led a very well-attended discussion about the realities and challenges of strategies and objectives and different type of methods to promote informative rapid cycle research, what constitutes rapid cycle, may be of differing length. Some people may say 90 days, and of course the duration of the study is informed by the objectives, but a shorter than multiple year approach. And also in their presentation of rapid cycle in this reference document that has been provided for you and developed through the APT funded PBRN, well, AHRQ funded through APT's contract with us, builds upon Dr. Gustafson's previous framework, which he will be presenting on how to proceed with rapid cycle research. And then in heeding some of the discussions in their continuing research, they have pulled together for you in the document and in their presentation very pragmatic examples. And so while the presentation will be quite lively, and as Christina said, it will be available online, we highly encourage you to take a look at this new resource and to avail yourself of the drill down of information to the various hyperlinks and resources. So with more of the background behind us, I'd like to introduce you to Dr. Dave Gustafson, who many of you know in the field. He founded and directs the Center for Health Enhancement and System Studies, otherwise known as CHESS, and he is a master strategist, both in his ability to bring people together and inform a dialogue, and also in to motivate advancements in quality and strategies for quality improvement and quality of life across different types of challenges, including addiction, cancer, asthma, and aging. He is extremely well published with more than 225 peer-reviewed publications, and 7 books. Dr. Gustafson is a member of the National Academy of Engineering, and he as well has many appointments and recognition of the gravitas that he has in the field. He and Dr. Johnson, who is the Deputy Director at CHESS and a research at the NITACs part of CHESS, and she is a leader in research activities at the University of Wisconsin, where Dr. Gustafson is as well, focusing on technology and process improvement. Dr. Johnson also co-directs the National Coordinating Office of Addiction Technology Transfer Centers, which consists of a network of 15 centers that provide training and technical assistance and clinical treatment for substance disorders. She is very experienced with respect to being in a managerial position for programs with respect to Women's Addiction Treatment Agency. But again, I will turn it over to the dear doctors now. Their greatest strength that I have seen is their lovely repertoire of conversation with one another and with us that gives us hope that incremental advancements can be achieved, and that there can be joy and work as so many of you seek to tackle very complex projects, processes, in order to improve quality of life for the patients and the caregivers that they serve. So with that very long-winded but heartfelt introduction, I will turn it over to our dear doctors in Wisconsin.
Thank you, Rebecca. Just want to make sure, are you seeing my screen now?
Yes, we are.
Okay, great. So this guidance document, what I want to say, this is Kim, what I want to say about this guidance document is it really was, came out of a process that we had with a group of experts that included Dr. Gustafson and myself. And I think at the end of the slide we have a thank you slide for everyone that participated in that conversation. And it was a very rich discussion. Every time we ended those conversations, we said, oh, we want to have more of these kinds of talks, because they were just great discussions about the process of doing rapid cycle research, and also just sort of sometimes philosophical discussions. One of the, I think, for me, one of the most profound statements that anybody made was, I think it was Lloyd that made it, was, you know, we had this conversation about the intersect, or where you draw the lines between quality improvement and research. And what Lloyd said was, well, in most industries, there's not this concern about where you draw the line. It's all research, and there are just different methods that you apply depending on the question that you're asking. And so I think that that's kind of the approach that Dave and I want to take to this presentation, and that we took to developing the resource guide, and that it's all research, and that what's most important is the question that you're asking, and that the methods that you use are dependent on the question that you're asking. And so that's the approach that we'll use here. We will spend most of our time, for that reason, talking about the problem identification, knowledge exploration, and solution development, because we think that that is the most important focus that we need to make. One thing I do want to mention about the guide and about our talk as well is that the little gears on the bottom of the screen are also the little gears on the bottom of the chapters of the document, or the sections of the document, and they basically highlight where we are in the process. So in the document, and I think on the slides as well, you'll see you'll see one of the gears highlighted, and that is the section that we're in. This is and I actually forget who came up with this brilliant idea, but this and I think this was coming up with this infographic was an iterative process as well. And really, this is just the sort of pictorial reflection of what we're trying to convey in the document, in terms of
in terms of the iterative process of answering questions or solving problems, and the gears or the steps in the process. And I'm going to turn it over to Dave to start talking about the first section, which is problem exploration.
All righty. Thanks, Kim. Thanks also, Rebecca. That was such a neat introduction. I don't feel like I deserve the comments that you made, but I wish my wife had heard it. So that anyway, we'll set that aside. The way in which we're going to approach this is that we're going to go through one section and then stop briefly to take questions. And has anybody said how the audience is going to enter questions onto this thing?
I think Christina explained how you type them into the chat box.
Okay.
So that's what they do. And then Rebecca will, so that we don't have to focus on that, Rebecca is going to then read them or compile them for us.
Excellent. That's great. So as we go through this, I'm going to start with problem exploration. And a couple of just comments on that as we go on this. A lot of the stuff that I'll be talking about will be sort of gimmicks or tools that I have found useful in my work in terms of problem exploration or really understanding our customers. And I hope you'll forgive me for using the term customer. I really think it's appropriate in healthcare as well as in other places. And I'm going to be talking about three tools in the problem exploration part. One is walkthrough, another is the nominal group, and the third is the critical incident technique. The slide that you see that is a matrix here is just, I don't know that there's anything particularly great about it. It just was, I took a few days at one point to just write down what I thought were some of the key learnings, the key ahas of my career, and I tried to take things that I thought were really simple principles that for me just made such a difference in the way in which I think about research and problem solving and that kind of stuff. And so on the left-hand side of this, what you see are various phases or stages in problem solving, and we're going to be following those stages pretty closely as we go through. The other three columns aren't ordered in any way as far as the columns are concerned, but you know, the rows, for instance, under problem exploration, you'll see walkthrough, nominal group technique, and critical incident technique listed there. So it just sort of summarizes those things. I just have found those three particular techniques to be really important. Another sort of introductory comment. I feel so strongly that diseases are not focused on a patient. Diseases affect the full family, and the family, as a result of that, has the potential. They can't always pull it off, but they have the potential to be an enormous resource in solving problems. And certainly, if a person gets sick, the whole family is affected. I had a heart transplant 7 years ago, and you know, it clearly affected the whole family. But more than that, my wife and kids really were primary reasons why I survived that experience. And so it's hard for me to think of a patient as being something that's treated in isolation from the family. So it's just a perspective I have. A second point of the brief introduction before we get into the tools is a lot of times I hear problem-solving groups saying things like, you know, how do we get the CEO to buy into what we're doing here? Or how do we get X to buy into what we're doing here? I think that's exactly the opposite question from the real question that should be asked. And the real question is, how do we buy into the goals or the directions that leaders have set for the organization? If I can take a problem and attack it and make a difference in the eyes of people who lead the organization, I'm going to have their support. And so I don't think saying how do we get them to buy into what we want to do is the right way of looking at things. I think that that's the final point, except this. Bob Dylan, and for those of you who are around the age I am, was a folk singer. Well, okay, yeah, Kim too. Where it was a folk singer, is a folk singer, and one of the songs he said he sang was, "You're going to have to serve somebody." And for me, I think the key point that needs to be had here is that we need to be looking at this as a sort of a servant leadership, viewing our role as making a difference in the lives of other people. And so that servant process is a key element that underlies everything that I do. So now I'm going to talk about the three methods. When I got a call from the Robert Wood Johnson Foundation about 10 years ago, or more than that, I guess, they asked me if I'd be interested in leading a national program office in trying to improve the efficiency and effectiveness of addiction treatment. I didn't know anything about it, and so I got myself admitted for heroin addiction. I've never touched the stuff. To this day, I still don't really know what it looks like. But I got myself admitted for addiction treatment in two addiction treatment agencies, one here in Madison and one in New York City. And as I went through that process, I tried to experience it exactly as a patient would. Now, I'm never going to be able to do exactly what happened, but I wanted to come as close as possible. So I stayed overnight in a detox facility. I stayed overnight in a residential facility. I spent time with clinical staff, better understanding how they thought through my process and the process of other patients. So I tried as much as I possibly could to really experience or walk in the shoes of, in that case, my customers. And all the way along, I would ask questions like, what can we do to make this process better for you as a counselor and better for our customers, or our patients and our families? And it was such a powerful experience, because I was able to really almost feel what it was like. You know, I'll never forget in detox seeing this woman who was really quite affluent in this detox facility in the middle of a concrete parking lot, and the embarrassment on her face, and her husband driving up in his Cadillac to pick her up, and the shame that he had. And you know, you just get such a much better sense of what's going on if you take the time to personally experience what it's like to be your customer. And now in our work in quality improvement, we literally require that any organization we go through does a walkthrough in their thing to better understand how a patient gets into treatment, what happens when they get there, force the CEO to fill out every form that the patient has to fill out, every time they have to fill it out, and things like that. It just makes such a difference. The second technique that I want to talk about briefly is called the nominal group technique. Many of you already know of this technique also, but the basic idea behind it is to, in a relatively short period of time, to identify, for instance, the problems that somebody is facing, or solutions that are being considered, and prioritize those things. So it's a technique that doesn't allow much interaction or discussion. You you have a bunch of tables. Each table has 9 people, or 5 to 9 people at it. So you may have just one table, you may have a lot of tables. You have a scribe for the table, and you go through 4 steps. But before you go that step, you come up with a task statement. Now the task statement shown at the bottom of your screen has one that's been tested pretty thoroughly over the years, and it just is a great way of asking the key question you're interested in. What are the most important personal and organizational barriers you face, and then complete the sentence. What are the most important personal and organizational barriers you face in trying to get in being treated for cancer or things like that. So, and the importance of the personal and organizational thing is to just sort of get people to think about themselves and how they're part of the issue and how it personally affects them, and then also the organizational issues. So there are 4 steps, and the first one is silent generation. You ask people to sit there and look at that test statement for anywhere between 5 and 15 minutes and silently list, each person individually without any discussion, silently list as many the most important ideas they can think of.
This is the hardest part.
Yeah.
No one can do it silently.
That's right. They can't do it silently, and 15 minutes feels like just forever. But it's really important. The second phase is then to go around the table and get only one idea from each person, and then continue around the table. And then once you've got one idea from a person, then go around again, and you put those ideas up on a flip chart. You briefly have a discussion to better understand the items that are up there and to argue for and against, maybe 20 minutes max. And then suppose you have 35 items up there. You give, you say you have, here's 7 stickies that you can put one on each of the 7 most important items that you see on that list. Or alternatively, you just tell them to go up with a felt tip pen and place 7 check marks. The reason behind this particular approach is because it prevents domination. You move in and you spend 5 minutes, everybody thinking about the problem, or 15, thinking about the problem and sort of getting their head into it. No discussion, nobody trying to influence your thinking. Round robin, one idea per person as you go around the thing, so again, preventing domination. And then the voting, so that, and discussion, very little discussion, so you can't, you can be influenced, but nobody can control the discussion, and then you vote. And it's a very powerful technique, but it's also very structured. And then the last technique is the critical incident technique. This, in my mind, really narrows down to basically just one statement, and that is what is it like? We've found over the years that people who are trying to identify problems or needs often will say things like, well, what do you need? Or what problems do you face? And the problem is very few of us really understand the answer to either one of those questions.
For ourselves, either.
For ourselves, absolutely right, Kim. And so what you need to do instead is to ask a question like, what is it like to be not a patient with breast cancer? It's very important that you take, we think, that you take a broad view of things. And so you don't say, what's it like to be a patient? You say, what's it like to be a woman with breast cancer? And then if you do that, if you do that, then you're giving yourself an opportunity to understand the breadth of the problems that you're facing. So I think if you go back over these things, the walkthrough, to personally experience, the nominal group, to get ideas from a group of people without domination, and the critical incident technique to really understand what it's like to be a person. Just one last point on that. If I remember when we were doing a critical incident technique on women with breast cancer, one woman said, I remember when I was first diagnosed, the doctor walked in, he walked into the room and he said, I'm sorry to tell you you have breast cancer. He spent the next hour with me and I don't remember one thing he said. And so that experiential statement lays out a critically important issue, and that is, how do you communicate information of this type in a way and in a time that the woman can really internalize it? So those are that's the first thing, the problem exploration tools. And so now if we have questions, and I hope we do, we'll take them.
So on the screen are the instructions, again, for typing in questions. Rebecca, do we have any yet?
So basically, the questions are more practical. Yes, we will send out the PowerPoint presentation to you at the end. And Dave, could you go back and kind of readdress how you explain the point about leaving the questions in a broad, critical incident technique? Maybe expand upon that?
Sure, sure. A lot of times, if we're interested in understanding what the patient is going through, we'll ask. If we ask questions like, "What's it like to be a patient of our organization?" You'll get some interesting information. You'll get thoughts about, well, gosh, I wish the parking lot were easier to use, and I really didn't understand the doctor on this particular issue. But we found at least that it doesn't necessarily get to the heart of what a patient is going through. That there are so many other things that are coming to mind. How do I take care of my kids? Who's going to be here for them if I die? Things of that kind that may not directly have anything to do with health care, but have such a critical role in the patient's situation that they, in the ideal world at least, they need to be addressed. Sometimes we don't understand. We say, I don't understand why our patients aren't taking a particular medication. I've told them to take it. And then if we understood that this patient also is working 2 jobs, it has limited access to time to pick up the medication, lacks the funds to be able to pay for it, it puts a different picture on the thing. In fact, it may very well be, I happen to believe, that most decisions to not take a medication are perfectly rational, given the situation that the patient is in. But we need to understand the breadth of the situation to really understand why they are taking their medication. And so a broad view of needs to start with is really important. You can narrow down after that, but the breadth, I think, is critically important.
Okay, great. So there have been several questions posed, some of which are with respect to complimenting you on this early stage of preparation and problem exploration. But I think it relates to maybe if you could reiterate for the folks on our call that there are separate methodologies that are applicable for the different phases, for the different gears that we show with respect to knowledge exploration, solution development, solution testing, and implementation dissemination. For example, one of the our viewers was wondering why you didn't discuss PDSA cycles, but that would be something to be discussed later on. So if you could just reorient some of our viewers about how you're going to strategize and present these different types of methods depending where you are in the process of exploration of the problem.
Sure.
Yeah, maybe we could, can I get control again, and then we can go back to the matrix maybe and show the progression. Okay.
Thank you for that question. It's really important, and a couple of thoughts. There have been, again, this is just my attempt to think through what things have made a big difference in my life, and the PDCA cycle, which is C on the left-hand side, is certainly a very important part of it. Some of as we go through, where we start over on the left-hand side, we just got through talking about problem exploration. And in problem exploration, what I tried to do was to emphasize 3 techniques that we found to be really helpful for us as we better understand the problems that we're going to try to tackle. And then next we're going to move into solution exploration, and there are some gimmicks or techniques that are there too. I wish we could cover everything on the matrix today. We can't. This is a selfish plug, but we do have, Kim and I have written a book on called the Niatex Way that is a more complete representation of a lot of these things. But
and the guidance document as well has links to lots of these resources that have a much more detailed explanation. So those two, and it may have a link to the textbook too. So
yeah. So I'm not going to be able to cover anything, and I'm not going to really stress the plan, do, check, act process here. Although I do think it's very important. It's one of those. We had to make some decisions about what to include and what not to include. Yeah. Rebecca, is that okay, or do you want me to go further?
I think that's great. So we look forward to problem exploration tools.
Okay. All right, so we've gone through the problem exploration stuff, and now we're going to move into knowledge exploration. On that matrix, it's I made the mistake of calling this solution exploration. It's not. It's knowledge exploration. And the idea behind this is that is that a lot of times we jump from working on problems directly into coming up with solutions. And we've found, and I think there's some literature behind all of these things. It isn't like I'm discovering the world here, but we've found over the years that taking a break between understanding the problem and jumping into the solutions are really important. And the reason for taking that break is for us to get some clues as to what a good solution ought to look like. And so when we talk about knowledge exploration, what we're talking about is a process where we reach out beyond the boundaries of our own industry to understand how other industries tackle the problem and what makes the best of the best so good in doing that. And so in the next few minutes, I'm going to touch base on those things. I think the reason why I'm pressing the idea of going up beyond the industry is if we look around in the industry and find out how Cleveland Clinic or Mayo Clinic or other places do these things, we'll see organizations that are operating pretty darn smoothly, I guess. But if the new ideas, the innovative ideas are going to come by understanding not what we're already doing in the healthcare field, but how other industries that tackle the same kind of problem are tackling that problem, and who are the best in that field, and how are they tackling the thing. And you know, it does a lot of things. It improves innovativeness. You get new legitimacy and that kind of stuff. So basically, and I'll give an example in just a minute that will hopefully clarify this. Almost the most difficult task we face is the first one here, and that's to characterize a problem in a general way. For instance, our patients a lot of our patients don't take medications. And if we sit back and say, let's see now, what is this really an example of? And you might come up with a number of different things, but you know, if we say, what's going on here? Well, the doctor says to the patient, I think you should take this medication. And somehow or another, the patient doesn't do it. Well, what's going on here? You know, well, the patient's dropped the ball, right? That's one way of looking at it.
Or the doctor.
Or the doctor. But the interesting point is that little comment, the patient has dropped the ball, hits the nail on the head. You see, it's a handoff problem. You're handing off the responsibility for doing something from one person to another. So now you've got the problem characterized in a general way. Well, what industries out there face a similar problem? Well, as it turns out, virtually every industry in the world is faced with this problem, and it's one of the most vexing problems any industry faces. How do the signals on a cell tower get transferred from one tower to another without losing a call? How does the nurse, when she is sharing information with the next shift, do it in such a way that that next shift is properly prepared to carry out their work? How does a football team hand off the football in such a way that they aren't fumbled, and things like that? All of these are handoff problems, and the issue is, how do we identify the best of the best in that industry and figure out how they solve that problem? And then once you identify those people, what sets them apart from the competition? Now, you may think that this takes a lot of time. This can be done in a morning. And I'll get to that later on. So I just went through this particular slide. Patients aren't following directions. Why aren't they following directions? Well, this is an example of a failed handoff. And we then ask ourselves, well, who are the industries that do this? Well, you know, when we were working on in addiction, one of the things that we found was only about 10% of the patients that enter in residential treatment actually make it through residential treatment, then move to the next level of care, make it through that level of care, and then move to the next level of care and make it through there. Because each time you move from one level of care to another, the ball's dropped. The patient says, I'm cured, I'm going to go, I'm leaving, that kind of stuff. So here are other industries facing that problem. One is NASCAR. Matt Kenseth is one of the better NASCAR drivers, and he has the reputation of having a great pit crew. And in the big handoff here is a handoff at the pit stop when Matt turns over his car to the pit crew. How does he get out of there in 18 seconds to be back on the track? Well, it turns out Matt Kenseth lives in Madison, or lives outside of Madison, and his pit crew runs a gas station, an automobile repair shop just up the street. So I went up there and talked to him, and I said, you know, what makes you guys so good? What's the thing that differentiates you? Then Paul Christ was our offensive coordinator. He's now our head coach in our football team. Please do not talk about our loss to Alabama this weekend. But Paul is considered to be an offensive genius, and he's just come to be our new head coach. And so when he was here earlier, I talked to him and said, what makes you so good? What are the things that separate you from others? And here are some things that commonly come up across the board when we're talking about handoffs. Number one, never blame the patient. It's never the patient's fault. Okay? There's something else going on here. It's not the patient's fault. That's the first attitude to take. The second thing is that if we really are serious about getting patients to take their medication, we got to take this handoff very seriously. Any field that is working in this area of handoffs knows that a commitment to solid handoffs makes all the difference in the world in the success of their organization. The giver and the receiver can't be a person telling A what to do. They need to view themselves as a team, and they need to respect each other as a team, and they need to work together as a team to solve the problem. The handoff process is standardized. There should be no difference from one patient, from one attempt at a handoff to another. The process should be standardized, and it should be practiced, 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 practiced. And very rarely do we do that. And the process and outcome of these things need to be measured and fed back to the organization so we know how we're doing. So, you know, I said it takes a morning. You don't need, all you need to do is the creative thinking. What is this process like? And then what other industries deal with it? And then who's the best of the best? And when you characterize the problem, you go to Google and understand how people are looking at the problem. There they'll tell you what industries are involved. Then you can find out who are the best of the best just by reading a little bit about it. And then chances are 99% that the best of the best have been studied by other people, and there's articles written about what makes them so good. So it can be done very quickly. But the fundamental importance here is don't jump directly from problem identification to problem solving. Take the time to understand the critical ingredients, the key things that have to be present in any solution before you start trying to figure out what that solution should be.
And you can see how that would help you be more creative in solution identification and not sort of leap to conclusions about what's going to work. When you're thinking about how can we think about this problem in a very different way, and who else has solved it in a different industry that might be a very different way.
Absolutely.
So we're at the point that we are ready for more questions.
So if I could just step back and while other people pose questions, going back to just taking the initial effort to understand the process from the perspective of the patient in the example that Dave gave, and taking the time to do that and the openness to proceed with that. There's some people who were questioning, how do you convince sponsors of the project or others who are engaged in such research to afford the team the opportunity to have someone or some people to really garner firsthand perspective? What have been some of the strategies that you've done to make that initial step seen and understood to be critical?
Well, that's really a good question. It brings back a general principle that I try to adhere to in all phases of problem solving. One key principle is I try not to label things when I'm really doing this stuff. So for instance, I would never say to somebody, now we're going to run a nominal group technique, or now we're going to do a critical incident technique. That's not important. What's important is just to do it and just sort of to slide into it. Why don't we take a few minutes here? We've got 7 of us here. Let's before we get into this, why don't we just take a few minutes to silently list, and that kind of thing. So the first thing is I don't make a big deal out of any of these things. I try to do it sort of quietly. I guess you'd expect that out of a Scandinavian, huh? But and the same thing goes with the second phase of knowledge exploration, because it can be done in a relatively short period of time, and because I can probably just close my office door and have if Kim and I could spend the morning together and do a knowledge exploration activity and nobody even needs to know about it. We can just do it and get it done. Again, not making a big deal of it, but then what we can do is we can walk out. And when we were doing the addiction thing, it just blew people's minds when we would say something like, we talked to Paul Christ, the football coordinator, about this, and people's eyes opened wide and said, "What?" And
people aren't footballs.
Yeah. Oh yeah, absolutely, they aren't football. But when you get beyond that, because you're taking such a different perspective, it really, I think, in most cases presents stuff in a different light, and as Kim said, and can be really useful. But I don't make a big deal out of any of these stages I go through.
And so I think sometimes some of this you might want to do before. So if you're thinking grant funding, some of it you might do before you apply for a grant, right? Some of this is helping you get to a place where you're ready to apply for a grant. So that's one way to think about it, if that's the funding source that you're thinking about. But if you're working in a healthcare provider organization, I mean, these are the kinds of things you probably want to incorporate regularly into your practice so that you are always asking the right questions. So it sort of depends on what your perspective is and where you're coming from in terms of how to incorporate it into your work.
Okay, thank you. So some of the questions are in response to some of the methods that you are articulating now, and rather drawing conclusions, but you're not in the position yet of identifying what the best next step would be, because you're at the knowledge exploration stage and you'll be pursuing other strategies for solution development and solution testing.
Absolutely,
and with that,
right. That's right.
And so, but let me just, with that background, offer one of the reflections. Are there questions you ask yourself that help you think about other industries facing similar problems to yours, and how you frame the questions and frame your search of other industries? How do you seek that resource out?
Sure, that's great. I realize these things sound maybe sort of silly, but I'll just walk down the hall and I'll say something like, I'm trying to think of another industry that has trouble with getting their either their staff or the organizations to follow orders. Okay, well, the military is one. What? So how? In what sense is the military one? And they go into that. I said, well, how about something else? And so one of the things that I'll do is I will just make sure I'm talking to 2 or 3 or 4 people, and maybe talk to them separately, maybe together, but just continue. I don't stop at the first industry. I'm going to get 5 or 6 examples, and they come out pretty easily once you can characterize the problem properly.
I think the hardest part of this process is getting your mind to the bringing the problem up to a level that it's a generalizable problem. So it's not just, like in the example Dave gave, not just the patient doesn't take the medication, but how do you generalize that? And I think that that's the one that's the hardest for people to do, and sort of making that leap to, okay, well, what in general, how can we characterize this problem?
I agree with you.
Yeah.
Yeah,
because once you've gotten there,
yeah,
it's a little bit easier to make that next step and say, well, what other industry has a handoff problem?
Right.
But it's I think the hardest part is that making that sort of just broad, generalized. Well, what is this an example of?
Yeah, and I think for instance, I'm just pulling this out of the air, but suppose we had a problem with our scheduling system. I would say, well, no. So what's another set of words? Let's get rid of the jargon and all that kind of stuff. Let's just say this in a different way. Well, people don't show up for appointments, or we don't have room. We don't have enough room for all the people who want to get treated. What's that? What other industries face that kind of problem? And so I think if you find that you're using jargon or terms that are hard for you to explain to a lay audience, get rid of them, say them in another way, then restate the thing again and again and again. And each time what you're going to be doing is finding a more generalizable way of characterizing the problem. And Kim is absolutely right. It takes patience, and it takes maybe talking to 1 or 2 other people, 3 or 4 other people.
Okay, great. So earlier in this discussion, Dave, you talked about the critical role of the handoff. And a very thoughtful reflection came back from one of the viewers where in some situations the handoff, such as a conveyance of information between transitioning cell towers, is quite clear whether there is agreed upon fidelity of the handoff, so to speak. But with respect to doctor-patient issues, shared goals are assumed or presumed by this viewer in the presentation. But in some instances, there may not be shared goals or shared values with respect to the doctor-patient relationship. So there may be misalignment of goals of that handoff or that point-of-care transaction. And what are some of the strategies that you've used to recognize that and mitigate it?
Sure. You're right. It is a very, very good reflection. I think that for me, I'm one of these guys that starts from the specific and goes to the general rather than the other way around. So, you know, in that particular case, I might sit down with, say, a doc or a nurse or somebody like that, and I might just say, can you think of a specific case of a situation where you just felt like you guys were talking past each other, that the understanding wasn't there, that there were some things that just were I don't know, out of sync, you know, and that kind of stuff, because it sometimes, and see, words like shared values for me are jargon, and so I wouldn't use that kind of a word. I wouldn't use values in there, but I might just say, you know, where it just feels like people are thinking about this very differently, and they're seeing it in different ways, and that seems to be getting in the way of your relationship with that particular patient. Can you tell me about it a little bit? And I might do that with 2 or 3 people, or maybe one person with 2 or 3 patients, but just get down to the specifics. And when I get down to the specifics and I eliminate the jargon, then what I do is I'm able to develop a much better understanding of what's going on. I don't know, that's probably an inadequate answer, but it's
I think it gives us lovely food for thought. There are a few more questions, but I'm going to hold those to the end so we can continue on with the next discussion area.
Okay, that sounds good. So the next step in this process is to begin solution creation. Now, again, you need to take me. I mean, this is just who I am. I like to do things different, and it's just who I am.
An engineer.
Yeah, I'm an engineer. What can I say? It's my father's fault. He was an engineer. But in the solution development phase, for me, a big step again is to think of things at a creative level. And so the thing I'm going to talk about here is an ideal systems approach to this. Now, earlier on, this particular issue came up in another way in one of the questions that was asked. But I think it's really important, and I bet you many of you have seen this particular picture. It's certainly not one that I drew the first time. But if on this scale, if we measure satisfaction on the up and down scale and measure the amount of a product or a service on the right-hand scale, I mean the horizontal scale, there are 3 different kinds of quality. Expected quality is the kind that that if you give me more of it, I'm not going to say, oh, thank you, thank you, thank you, because frankly, I expect to get that. And so I'm not going to be particularly impressed by having Delta Airlines say we don't crash. Because, you know, would I get on a plane if I anticipated it was going to crash? Only under some very weird circumstances. But on the and so what you see here is a picture where you go more, as you give more, you notice satisfaction doesn't go up. But if that plane crashes, you're in deep yogurt. You're into hundreds of thousands, if not millions upon millions of dollars of cost, or bad press, or other kinds of things. And so you put a lot of work into quality assurance to make sure that the disasters don't occur. but by giving me more, that, you know, by trying to go further, I may need to go further, but your customers aren't going to say thank you. In terms of desired service, the next picture there, you're finding that the more you give a person, the better off they like it, and the less you give, the less they like it. And so, you know, if you make it hard for me to park, if you give me crappy food when I'm in the hospital, you know, those kind of things, or not, you know, right. If you give me more of it, I'm going to appreciate it. If you don't, I'm going to whine about it. And so that's what's called desired quality. I know what I want, and I know whether you gave it to me or not. The third kind, though, is the kind of quality that distinguishes organizations. It's the kind of people who have come up with a solution that blow your socks off. And this is a situation where if you don't give it to me, I don't say, where is it? Because I didn't know I needed it. I didn't even know I wanted it. But if you give it to me, I'm going to say, wow, that makes an enormous difference. And it's this third type of quality that at least I have always been intrigued by, because it's the thing that allows me to distinguish the solution. And so I'm going to pass over this slide here and go into an example of it. So we talked about essential ingredients, and suppose, well, I guess I do need to go back. The top of this picture, the top slide is after we did this, what is it like to be a woman with breast cancer? We then created a survey. The darker lines are things that came out of the what is it like kind of interview. The light blue lines are what you find in a typical patient satisfaction survey. And then we send it out to a bunch of people to get ideas of relative importance. And one of the things that stood out was the things that were really important to these people are factors that came out of what is it like. And I mentioned one of them earlier, and that is you know, having time and knowing what questions to ask and that kind of stuff. But one that really came out strongly for breast cancer is, you're telling me that I have to have a lumpectomy or a mastectomy. You're telling me that that decision is pretty important, but you can't tell, but you don't know which one is the best. And you tell me, well, come back in a week or so and let me know what you've decided, which is what happens in breast cancer very often. And so all of a sudden you're just locked in. What do I do? How do I make this decision? And so that's an example of some of the those darker blue things on the surface. I apologize for the phone ringing in the background. It'll go away in a minute.
One more ring.
Yeah, one more ring. So that's the problem we're trying to solve, is how do we help women make better decisions? Well, regardless of what actual solution we come up with, it feels like there are sort of three categories of essential ingredients that have to happen. One is the women need to have social support in order to feel comfortable in the decision they're making. They need to have the kind of knowledge and skills at coping with stress that will help them, and they need to have hope that there's a reason for making this decision. There's hope that it will lead to good consequences. But then now, how do you take those ideas and how do you put them together in a solution? Well, in this particular example, we just didn't make a big deal of it. I just asked the breast cancer doctors in the university hospital here to give me a list of patients, that women with breast cancer, that they thought were really creative people. Also asked nurses and other people like that. And we came up with 7 women who had a reputation for being very creative, insightful, who were recently diagnosed with breast cancer. We brought them together, and I just said to them, look, do me a favor, would you? Let's pretend for a moment that while I might not be able to just make your breast cancer go away, I had all the money in the world to help you out in terms of coping with this thing. And and no restrictions. I just want you to blue sky and tell me what, in the ideal world, you would like your breast cancer treatment system to look like. And I just kept on emphasizing for a minute or two how important it is to just don't worry about any real world restrictions. Just tell me what you're going to say. And so, let me check to see here. And then they sat there quietly for a few minutes, and then I said, okay, so what'd you come up with? In this case, I didn't do the whole nominal group technique. I just did the silent generation part. And one woman said, well, you know, I would like to have a semi-truck trailer with all the literature on breast cancer driven up to my house. But I want that literature to be converted over to a language I can understand, and I want them to leave that truck out in front of my house until I'm done with it. And then another woman said, well, I've got an extra bedroom in my house. I want my own personal oncologist to move in so that she is there anytime I have a question to ask. And another woman said, well, I want to have 10 women just like me. And I want them, but I want them to be at different stages of recovery. I want some of them to be 10 years out. I want some of them to be 5 years out. I want some of them to be 1 year out. And I want them to all move in with me. And I want them all to have similar demographics, similar socioeconomic situation, similar personality, and I want to be able to talk to them whenever I want. And then another woman said, and I want a relaxation guru to move in with me. And so that was the kind of conversation that came on. And so then we moved to the next step and said, okay, so that's the ideal. How do we come as close as we possibly could with, and because I'm an engineer, I tend to use technology. And so we sat there with these clues that the women have given, and the semi-truck is the middle thing, and the arrow pointing at a thing called news, and it was what we called the instant library on the computer. And the personal oncologist turned into an Ask an Expert that people could write messages anonymously to and get answers back in 24 hours. The relaxation guru included audio tapes of relaxation skills. The 10 women just like me turned into a discussion group of an anonymous discussion group, and so on. Now this all took place in 1989, and the first chess system that we developed came into operation in about 2001, thanks to support from the Kellogg Foundation. But the point is that we started out with an ideal system with a bunch of nonsensical ideas, and then we took the time from that. We took the time to go from those nonsensical ideas down to a practical way of approaching them, and we came up with chess. Now, I don't mean to suggest in any way that money is a good indication of success of an idea, but that one idea led to probably $50 million of research grants that came in over that, probably more than that, and you know, and it certainly has influenced the thinking of a lot of other people. And it came down to just having those 7 women sit down and blue sky ideas, and then figure out how you move to the from that to a practical idea. So focus on the key needs of the customer, identify the essential ingredients, get a panel of creative customers, get them to design the ideal system, convene a panel of technologists, and find a way to go from that ideal system to something that's real world and practical. And you know, again, I'm not the creator of this idea. It's been around for a long time, but golly, it makes a big difference in coming up with great solutions.
I think we are at the point where we can take some more questions.
So as folks pose questions, one thing to reflect upon as Dave and Kim began, that the particular document that they're referring to as the Rapid Cycle Guidance document not only encapsulates some of these real-world, first-hand research projects that Kim and Dave are speaking about, but it is embroidered and informed by a group of PBRN, Practice-Based Research Network researchers, application of these different strategies through their own research, and provides other material that you can drill down into. Now, we have the metaphor about rapid cycle on a road. There are actually Route 66 really impressive citations in the document, and Kim was the primary author of a series of examples of how one would apply different strategies, methodological strategies, in the different phases of exploration and development that are really easy to read and quite informative. So there's much more in the document itself that I think may resonate with many of you. The way it is organized, it's easy to search and pick out not low-hanging fruit, but really nutritious fruit. With respect to a few questions, so if folks could send some questions with respect for the solution development, that would be great. But well, if you don't mind, should we step back? And there were a couple other questions that I didn't pose to you, if that's all right, Dave and Kim.
Sure.
Okay. With respect to just the very beginning, the critical incident technique, they were rather concerned with the phrasing and why that is labeled in that way. They would have thought that such an approach would be the review of an airline accident or something like that, something patient safety specific. Could you reflect upon that statement?
The language of critical incident technique.
Oh, you mean the label for it?
Yeah.
Oh, yeah, that's an interesting point. You know, the term goes way back for years, and I see the point. Sure, it does take on. It has been used in those kind of things, like in accidents and that kind of stuff. But I think and see the trouble you get into when you use labels. I probably never should have called it that. I guess for me the key point is getting people to think back on an experience that that helps them articulate what is going on in their minds. And so one of the things I didn't say, for instance, is I might do this sequentially. I might start off and say something like, well, think back to when to that first diagnosis, and I might even help them relive that a little bit, although that can be painful. I might say something like, what hospital was it? What did the room look like that you were in? Who was there with you? You know, what happened? He walked in when the diagnosis was given. What was it like? What do you remember that stands out in your mind? And then I might go on and say, okay, you left there and you're home now, and obviously it's one of the worst days of your life. Can you remember anything about that? And talk to me about that, so they begin to relive that experience. And then I might say, well, what was it like? What stands out in your mind? What are the things that just come back to you with you know, a flood of thoughts? And so I tend to just go through that, leading them through for a while through the various stages, you know, then talking about the surgery and talking about, if they had it, the chemotherapy and that kind of thing. And I just take them through. But I can see that the critical incident technique label probably was an inappropriate one. Thanks for that clue. I'll try to avoid using it in the future.
Okay, I'm going to try to read verbatim if my glasses will let me. One of our commenters said, I appreciated your remark about not immediately jumping to solutions and strategies to draw out ideas from patients. Where does the review of the literature fit in the process to see what is already known about a phenomenon?
Yeah. Well, I think that's the way I do the essential ingredient part of it. That's when I normally go to the literature. I've got to confess one of my real weaknesses is that, and it comes from my training as an engineer, I'm not a fast reader. And because I'm not a fast reader, I don't read much. And so I myself probably would not be inclined to do much of a literature review. I might ask friends who do read to tell me the 2 or 3 best article on a subject, and I might read that. And when I Google, you know, what I'm going to look for is I'll just go in, get articles from Google Scholar but also elsewhere, and I'll just skim them to get a rough idea of whether it makes sense, and then I might pick out 2 or 3 articles that I'll read in depth. So that's how I tend to do it. I wish I was better at doing the literature review stuff than I am. I tend to try to get through that part. I try to like to do things fast, and so, you know, this whole process that we've talked about so far is something that I can do in a day if I need to. I can do in a week if I need to. I can do in 3 months if I need to. You know, they're just ways in which you can crash it together, and the literature thing is a good example of it. I won't read a lot. I'll try to get nominations of good articles to look at, and I'll skim stuff out of Google that'll help me.
Would you say, Dave, that generally the sort of phase that activity comes in is in the solution development phase? So you don't want to do that too soon, or you're going to do what we were trying to get people not to do, which is jump to the solutions without.
Right. Yeah, I think probably the place actually where I'll spend most of my time is in the essential ingredients or in the knowledge exploration phase. That's where I might do some reading, because I don't have time to interview people from other fields, and I don't have time to, well, that's what I don't have time to do. And so what I'll do is try to find people who've already done that, and do that by going into Google Scholar and Google more generally.
Okay, great. Thank you.
No other questions?
Well, one isn't quite pertinent, but maybe you want to go ahead and take it?
Yeah, or we could leave more general questions to the end, because we have, I guess, 2 sections left. And
yeah, yep. I think that would be better.
Okay, let's do that. Okay. So we're going to spend very little time on solution testing, and I'm hoping that that wasn't what everyone was hoping that they were going to get on this presentation. The document actually does have a number of different strategies in it, and we're not really going to cover those very much today. So we'll just say a few things about solution testing, and this is where the PDSA or PDCA comes in, I guess, is that we're doing rapid cycle tests, not necessarily change, right? We're testing ideas. So we've identified some ideas that we think might work, and so we're going to test them. The change comes once the test shows something that works, but you have to test first. People with rapid cycle, people either think rapid or they think cycle, and both are really important. So fast with multiple cycles, it's an iterative process. And we have to remember that, and that's, again, that's where the PDSA or PDCA comes in. Getting it right the first time is not the goal, right? We're trying to identify things to test. We're doing research. We're studying. We're learning. So we try something, test it, figure out what's wrong with that idea, what's right with that idea, revise it, test it again. And rapid, so we've had one of the things that we had these conversations about when we were working on the document and had the experts was, what does rapid mean? And everyone has a different answer, and this is Dave's answer in here. Within 30 days, but my answer is it depends on what it is you're trying to, the question that you're trying to ask and the problem you're trying to solve. But 30 days, I think everyone said less than a year, and nobody had anything that was longer than that. One of the issues that people think about is in terms of testing is how do you know how do you know what you've done is the right thing, or how do you know when you've answered your question? And that I think this is probably the second hardest thing to do. The first one is I think the hardest thing to do is to get yourself sort of above the specific question you're trying to answer and characterize it in a general way. And then I think for many people, figuring out how you know whether the solution worked or not, how you measure it, is probably the second hardest thing to do. And you have to be clear about that ahead of time. I think for scientists, having few measures and not getting lost in data is the hardest thing. So for people who do research for a living, I think that's the hardest thing. It's for us, I mean, we have these conversations here all the time. You know, we have a clinical trial we're just launching right now, and we have an interview that we're doing at 4-month intervals. So we're asking the questions a lot of times, and it's a really long thing because we keep, you know, Dave will say, well, I want to know this information. I'll say, yeah, but I also want to know this other information. And then we have another researcher that has this other 20-question thing that she wants to tag on. And really, you know, all of it would be great information to have, but it's going to slow down our process. If we ask all those questions, it's going to make us lose people in the, you know, so there are all kinds of problems when you have, when you ask too many questions and you get lost in your data. The other thing, and I'm using this question Dave asks all the time, what could possibly go wrong, but I'm using it in a different way, because I think in terms of measurement, that there are two things. What is the question? What is it you want to know that's important? But the other thing is to think about, well, what could possibly go wrong? What are the consequences of my being wrong? And sometimes, you know, we always, in research, we always put the emphasis on type 1 error. I mean, we always do that in research, but that may not be the most negative thing that could happen. So I think that's the other thing you have to think about, because that goes into your study methods. What you're going to do is what are the negative consequences of being wrong in implementing a wrong solution. And so I think those are the important things about measurement is being clear about what it is you want to know. Don't let yourself get lost in data. And I say that knowing that we make that mistake all the time. And thinking about what are the consequences of me being wrong. And that's really, so there really isn't a right or a short version of the methods to use or the testing methods to use. It really depends on what you're trying to learn. And so that's really, we have some, in the document we list some options that people have used that are rapid cycle methods, but it's also not an exhaustive list of what the rapid cycle methods are. And people are kind of coming up with some creative ways of measuring now with all the data that's available in secondary sources like medical records. People are coming up with creative ways of using data that already exists in studies so that you know, 3 years from now there'll be so many more new methods to test and measure that's not really, I think we want to focus on getting the right question asked and measuring it in the most simple way. So I don't even know if there are questions for that.
Could I toss in an example?
Yes, do.
Yeah. I apologize again because this is an addiction example again, but I hope you can transfer from that industry to the industry you're in. When we first got started in that field, we visited a lot of addiction treatment agencies, and the key thing was it just takes so long to get into addiction treatment, and so we looked at the schedule books, and we would find the schedule books were filled. There just weren't. They just were. Every appointment slot was filled, but in about 35% of the cases, there was a line through it that said canceled, no show, canceled, no show. And I remember talking to this one lady in a treatment agency, and she said, you know, I don't even know why we bother to give people appointments. And that one sentence was just such a critical thing, because then one treatment agency said, you know, why do we bother with appointments? And they said, I wonder what would happen if we stopped giving appointments and just told people to come in when they feel like it. And so they said, well, let's try it. Not let's change anything, as Kim was saying. Let's try it. And so they said, well, let's try it with the first 3 patients that call. And we'll just tell them to come in. And we're going to assign this one person to handle those patients. So, and they said, let's do it tomorrow, and then let's see what happens. So they did it, and they got together and they talked, and it worked really well for 2 of the patients. They just were in treatment. They couldn't believe they were in treatment by noon, when on the average they had to wait 7 weeks to get into treatment. And so, but this one person had to work and couldn't come in. So they got together that night and they changed the idea a little bit to take into account people who worked. And then that Thursday, they had done this on Monday morning. That Thursday, or Tuesday, I guess it was Tuesday morning, whatever. That Thursday they tried it again, but this time they tried it with the first 5 people that called, and they set aside 2 counselors to do this thing. And and then they got together and talked about it again and came up with solutions. And they thought, wow, this works pretty good. We might want to try. Why don't we? And they gave it one more try, cleaned it up a little bit, and then they said, okay, that's it. We have now stopped taking appointments for our intensive outpatient program. Their intensive outpatient program within 4 months went from 16 patients in the program to over 106. And
which created different problems.
Which created different problems, but it also,
good problems to have.
Yeah, one of the problems that it created was they went from losing $200,000 a year on this program to contributing to margin by over $1 million. But the point is, you know, when Kim talks about rapid cycle, they did it very quickly. They tried it with a few patients. They didn't try to do anything fancy with measurement. They just said basically, how did it work? And then later on, once they went through 3 cycles, they had a solution that they could try, and that solution has spread to many other agencies. Certainly not half of them, but to many other agencies in the country. And so I think this rapid cycle thing has enormous potential. Period.
Let's go to implementation.
Okay.
And then we'll take questions after.
Okay. So then let's finish off before we go. Before we quit, let's take the last thing, solution implementation. Here, the particular technique that I'm going to do is talk about is a particular measurement device that we have found to be really useful. About 10 years ago, some folks at the British National Health Service were saying, you know, we try out all of these quality improvement projects, and within a year, the change we put into effect is gone, and they're back to doing it the old way. And so, how can we change that? And so we got together with people, with some folks over there and developed a particular model of an equation, if you will, and tried to figure out what kind of things did we want to measure to predict whether a change would be sustained or not. And in that process, we came up with this picture that you see here. We looked at the factors that people identified fell into three groupings. One thing had a lot to do with the staff that were involved. Were they properly trained? What were their attitudes toward the change? What did the senior leaders feel about it? What did the clinical leaders, were they supportive? And then under the organization, did people think about the infrastructure that needed to be modified in order to implement this change? And how did this fit with the goals and culture of the organization? And then under process, they thought about, well, how do you go about monitoring the change to make sure it's still working? And what's the adaptability? Can it be adapted to a different kind of organizational settings? And how credible is the evidence? And then the benefits were, you know, they don't want to make any change that's not going to help the patient, but what benefits did it have for the staff? Did it reduce their work? And from it came this sustainability model, which you can get as part of the document that is available. It is basically 10 questions that are applied. I'm not going to go over the 10 questions. They relate to the things that we talked about earlier, but I'm just going to take one of these things, and that's benefits. The top one on this thing. One factor was, what are the benefits beyond helping patients? And the ideal would be if the change improved efficiency and also made jobs easier. The worst thing would be that where it maybe even makes jobs harder, and then in between. And so what you do is you look at your situation, you look at the change and how it affects the staff and that kind of thing, and then you say, well, which description does it come closest to? And somebody might say, well, it does make some improvements in efficiency, but boy, I don't see any way in which it's improved things for the staff. And so then I might give that a score of 4.7. And what you do is go through these 10, you circle the number that comes closest, and you add them up. And that's all it is to it. It's a pretty simple process, and it's been implemented in the British National Health Service and been used in the Swedish county councils and other places. One thing you can do is you can get a video, a CD that will ask those questions, will analyze the data, will tell you what kinds of areas you need to work on in terms of improving your chance of sustainability. And then what we did was we interviewed a lot of experts and said, well, suppose you're in a situation where things aren't better for staff, but efficiency is improved. What can you do about it? What are some of the steps you can take now that you're in this fix to get out of it? And so you can get that, and we've given you the
link to the online version.
To the online version of that particular system. So that has turned out to be, I think, a very easy technique to use to try to figure out whether the change you're about ready to put into effect is going to be around a year from now. So,
thank you very much. We've pretty much run out of time. I just put a plug in again for the actual rapid cycle guidance document. Take a look at it. Look at the other cross-references within it. This is the last national webinar being conducted by the current and known incarnation of the Primary Care Practice-Based Research Network. which was started by Dr. David Lanier, carried on by Dr. David Myers and Dr. Michael Parchment. And of note that you see on the screen is in the most recent incarnation of the PBRN Resource Center is we have really, as evidenced in today's presentation at the guide, benefit and drawn from the breadth of experience in appealing, albeit not anecdotal, methodologies, and highly encourage you to review and look at our PBRN website and take a look at the webinars that we have posted as well. We're in the process of securing enduring CE credit for both nurse practitioners and clinicians. And with that, Christina will bring you over to your opportunity to earn some CE credit for today's participation. And albeit our last known national webinar, if you could take the time to evaluate and give us feedback about the presentation and your experience cumulatively with this program, it will be much appreciated. And even though this is the last webinar, we have one more document coming out in the next couple of weeks. The PBRN Business Opportunities with Affordable Care Organizations, Other Healthcare Systems, highlighting different business relationships that practice-based research networks have used to offer and get paid for providing training and technical assistance to other healthcare systems. So I encourage you to keep an eye out if you're part of our PBRN listserv, or otherwise, if you're part of the AHRQ process for disseminating information, you'll see a notification about that as well. So thank you very much for participating, both Drs. Gustafson and Johnson, and thank you to Dr. Gabriela Neva-Sadie, who has been the project director for the last 3 years of the PBRN Resource Center, and her wonderful team, including Tanner Broomer and Christina Shuto, Megan Wu, and many others, and the participation of folks at the McCall Institute, including Michael Parchment, Judith Schaefer, and Rob Penfold, and others who I don't have time to mention. They have produced an awful lot of information in a compressed time that we hope you'll be able to use for a much longer time. So thank you, and good luck in all your research and dissemination and implementation efforts. Take care.